Good morning from the Mount Sinai Cath Labs in New York City or anywhere you may be, any time of the day around the world. I'm George Dangas and I have with me Dr. Vishal Kapoor. We're going to accommodate this great case of popliteal intervention. But before we get started and go to the cath lab, let's just make some reminders. First of all, our next appointment here will be in April 27, same time, anywhere you may be around the world, or 8 a.m. Eastern Standard Time here in New York. Vishal, why don't you tell us a little bit about the website that hosts this endovascular cases?
Right, so it's at peripheраlinterventions.org. Please log on to it. You'll see all the archive cases from the previous months to go over it. And for this case, it'll be logged on by the end of the week. Just a reminder for our annual conference, please, for the CCVVC Symposium, which is scheduled to be held June 14th through 17th, please log on to the website cccsymposium.org to register. And for this case, we'd love to hear any inputs from you. You can email us at info@ccclivecases.org. Now we'll just go up to PK and see how's he doing this morning.
Yeah, in case also, remember the archives button. If you miss some parts of this case, you can see the entire case in the archives, or you can also see all the past cases we've done.
Show me above, guys.
Let's go to the cath lab. We also saw Dr. Guja already for a split second. And we have Dr. Christian as well, Ray, Roscano, and looks like they have already started the case. Dr. Guja, what's going on there? We like your mask. PK, you have great glasses.
Good morning, George. I wanted to let Karthik go ahead and talk to you about this case and go over the angiogram. Sachin, do you want to present the case?
Yes, sure.
And then Dr. Guja will go over the angiogram?
Absolutely. Here we have Dr. Sachin right now to start presenting the slides.
Some
of the case.
dinosaurs.
Come to the slide, please.
All right. So I'll
good.
Okay. Good. Go ahead, Sachin.
Good morning, everybody. I'm Sachin. So we have a great case today. Our patient is a 74-year-old gentleman presenting with the right foot non-healing ulcer on the dorsal aspect. He's Rutherford Grade III, Category 5, Fontaine 4, and his Wifi classification is 1-1. His past medical history is significant for coronary artery disease, status post cabbage in 2014. He had a peripheral artery disease with the stenting of the right SFA 2 months ago with the hope that the ulcer will heal. So we opened the inflow at the time. And then PTA of the left SFA and left AT in 2014. He also has hypertension, diabetes, dyslipidemia, motor vehicle accident, status post spine surgery. His current medication include aspirin, Plavix, Lopressor, Insulin, a statin and antibiotics for his ulcer. ABI was done after the fixing the inflow, showed a right lower extremity of 0.3 and left lower extremity of 0.8. Ultrasound was done that showed a patent SFA and the chronic total occlusion of the right pop with the 3-vessel runoff but severely diseased infrapopliteal vessels. So the plan for today is a percutaneous angioplasty attempt of CTO of the right pop and opening AT and PT. I just want to go over this slide that shows this patient comes under Wi-Fi classification of 1-1, and as you see here, 1, 2, and 1. So this patient has a moderate risk of amputation, and if you revascularize, this patient is going to highly benefit from revascularization. Back to the cath lab, Karthik and Dr. Krishnan.
So I'm going to have Dr. Guja go over the films. I'm going to just stop here for a second, let him go over the films. I'm going to tell you what our approach is going to be. If you can go over the angios we've taken so far.
Better explain to us, Karthik, what's going on in this case.
Dr. Dangas, I got trained by Dr. Krishnan and you, so I'll go ahead how we normally do it. I'll introduce the team on behalf of Dr. Krishnan. We have Dr. Krishnan, the director of the lab. I am Dr. Guja. I think most of you guys who are watching me know me. I'm the assistant director of the endovascular program. We have Ray Lascano, our famous NP here. And we have Chris here, who is our tech. We have Liz, the best nurse we know. And we have a great camera team around. So let's go to the gentleman as Sachin was talking about it. I'm sorry, we're having some, okay, got it. So,
Oh, great.
sorry about that.
That is your iPhone?
That's
the iPhone.
our testing this morning, I guess. Right. So, this gentleman initially came in with a left leg ulcer which healed now. and he had resting coagulation on the right side with a CTO of the right SFA initially about 5 months ago. And then basically the whole thing was occluded from proximal SFA down to the pop. And we just atherectomized the whole thing, and we DEB'd that we normally do in Mount Sinai and try to focal stent it. And I just focal stented the mid SFA. You can see it here. The stent is widely patent. Most of the SFA is nicely patent with some mild diffuse disease. Now we go on. You can clearly see there is a popliteal CTO. So this is a popliteal CTO. So we tried attempting it last time because of his claudication issue. We wanted to give him an inflow and see how he does. He has done very well until like 5-6 months. Then he started complaining of claudication now again, about resting pain now. He has severe diffuse disease of the infrapop vessels. You can see there is a segment of popliteal from, you can say from prox popliteal until the distal is like total. I think there is some false channels, a lot of collateralization that gives you an idea that how chronic this total occlusion is. And then I think the reconstitution.
This patient had an ulcer in the past and it healed after the SFA intervention?
Yes, so he had an ulcer about 9 months ago. So it healed after we did the inflow for the right SFA.
Okay.
But he still has resting pain. But the ulcer is healed completely. So we wanted to give him some time, but apparently looks like he has done very well with just inflow disease. But because of his resting claudication and a little bit of scarring, we wanted to attempt this popliteal CTO. The collateralization happens significantly and reconstitutes into the peroneal, which it looks like the robust vessel. The AT and the PT are occluded again. But you see that the peroneal actually gives collaterals and reconstitutes the peroneal coming down mainly and gives first collaterals to the AT, which actually reconstitute into the dorsalis pedis, and then to the PT. Both the vessels look like they're diffusely diseased. Even for infrapop axis, I think we can get the infrapop axis, the tibial axis for these vessels, but they are like just diffusely diseased vessels. So I think attempting antegrade is our primary goal.
Yep, so I think that was a very good overview of the angiogram. So George, as you can see here, we've got a challenging lesion with the popliteal that's been occluded. Looks like there's been an attempt made, because you can see there may be a dissection channel there. So the whole point is, how are we going to find the actual lesion or the actual entry point? So I think two things everybody needs to understand. First is, you definitely want to go to different angulations to try to see if you see anything which looks like a channel for you. And this is actually a pretty good angulation right here, which actually shows you, this is a LAO projection, which shows you that it's probably a posterior takeoff of the popliteal at that level. So what I'm going to do is I'm going to do a road map at this level. I've got a steering catheter and do it. So there's a steerable vert-tip catheter at this level. And I think there's a posterior takeoff of the popliteal by the double shadow that you see. So what we're going to do is we're going to go with a wire, a nice coronary CTO wire, and we're going to try, at this particular case, we're going to try to use the Confianza, and we're going to try to just probe. Interestingly, if you looked at the angiogram that Dr. Guja showed you, you have the perineal giving rise to the anterior communicating branch, which gives rise to the what is it called? AT
and PT.
Anterior tibial artery, and then you have the second thing you have is the posterior communicating branch gives rise to the posterior tibial artery. So you can see here that this does not feel very good, but now I'm going to go ahead and take a picture from above, just to show you whether we're heading in the right direction. Or put me on DSA now?
Yeah, we are on.
It's very tricky, and we said before, we had a reflex comment as soon as we saw the first angiogram, there are too many vessels. And I can tell you this is a problem, because angiographically you don't understand exactly if you are in one of the, where you're going to be, or in one of the side branches, or what's happening with that. And it makes the whole situation very difficult, just because the angiography is confusing with all these branches, collaterals, and combinations. It's very tricky. So you need to do all the angulations that PK said, very importantly, to try to understand what's going on.
And George, you can see here in two views, we seem to be heading in the right direction.
Yeah. We like it.
We might be in that dissection plane that was created earlier. Put me back on coronary, guys. It might be on that dissection plane that
Well,
was.
as long as we connect distally, it doesn't matter where we are.
Right, exactly.
But the
Back up,
direction
guys.
is good. You don't seem like we're already out or something. What do you think, Vishal?
No, I think it looks very promising here. My only concern is, do you have any, both Dr. Dangas and PK and Guja, of course, do you have any experience with going subintimal in the popliteal segment, especially when people are concerned about the popliteal aneurysms being one of the concerning factors? I mean, everybody wants to be intraluminal, but is there any specific concern of being subintimal in the popliteal segment?
Give me a.
So PK, I'll answer on
Well, I
behalf of
mean,
PK
let me
because
just
it's
say that
considered.
this guy, I mean, this is not the average case. Essentially, there's no popliteal right now. So
Right.
there is no downside in this particular case. In general, you're right. If there was a well-formed popliteal and this and that, but over here we have at most 1 cm of the popliteal, we have occlusion up top, and we have branches or I don't know what else below. So I think right now you know there is no option but to just try to do your best. This
Give
is
me an
clearly an
overlay for
outlier
G as well,
popliteal,
Liz.
not the average
Right.
popliteal. Actually, way away from the average popliteal.
So you can see there the wire started to fracture. So we went ahead, we got rid of that wire, and now what I'm going to do is go with another Confianza, and I'm gonna switch to an 018 Terumo G. A Terumo G is a 300 length gold tip wire that's going to help us to guide this one in. So right now I'm just going to go back in, try to find that channel again, and people may be like, why aren't you in a lower size catheter? The whole bottom line here is I really need the steerability to get away from the collaterals. So I'm just going to have Dr. Guja to give me a roadmap here again, so I can get back into that channel.
So somehow you advance the catheter a little bit inside the channel,
Right.
or maybe not. We'll try to find it. Now you pulled up a little bit. I think
I had to
you
pull
were a
up
little
because
like that.
I prolapsed back into the. Can you
I
bring the slave monitor to my zip code, please? If you look at where we are, I can barely see the screen here, unfortunately, and so I
Well,
can't
we
really.
see you very well, though.
I cannot see the wire at all. So
The wire is not approaching yet.
okay, thank you.
Yeah.
So now we're gonna go. Here we go. So let me see when I can get back into that channel.
Looks like you are.
No, but that's not the channel though.
That's
There,
probably better.
that
PK.
That's it.
There you go.
That's it. Wait. PK.
I don't know. I'm not convinced.
Take a picture.
Okay, come down.
Let's take a couple of orthogonal views down there. Definitely looks promising, and you're far distal, so
Yes,
we
sir.
can understand a little bit better what's happening. Where the bones meet in the joint, behind the joint, is where we have
Yeah,
too many
Yes, sir.
vessels.
Yeah.
Down there, maybe not.
Oh,
Looks
well, it's
good.
right there.
Looks.
I look
Right on top of
like I'm
I think we are in a
subminimal.
dissection.
Yeah.
But
Let's see if you can navigate a little bit there.
Uh-huh.
Right on top of it, so.
Yeah, I'm gonna have to just.
So Vishal, answering your previous question, I think normally you would want not to stent a popliteal. That would be the ideal situation. But looking at these collaterals, Vishal, I think this is really chronic.
Yeah.
Based on the amount of collaterals, you can know that this is chronic. The wire is fracturing, so you can see how stenotic how fibrotic this lesion is. There's not much
Looks like you need a
calcium.
little bit of a terminal curve. If you can advance the
to another
catheter
picture.
and add
Go
a
to
little
another-
bit more terminal curve there, you may pork.
I think it's important here to go to another view just to see
Yeah.
where we are. Ready?
Exactly.
Yes, sir. Inject.
This tells you don't need calcium all the time in peripherals to have difficulty. This is just fibrotic lesion, chronically close. So
Okay, that's great. Let's see how that navigates. You don't want to work on roadmap in this view? That might be very good.
drilling my
I'm just finding that plane again, Torker. Let's get a anterior catheter here, guys.
You want to use a macro catheter to support this?
No, anterior is like a re-entry catheter, like we have crossbar system in crossbars and Stingray in coronary.
Yeah, we'll have to go a little bit more further with the wire to do that.
Yeah, it's
Let's-
like when you have
Let's do a roadmap here.
I still think it may. Just try a little bit more. I think it may fall back.
Let's do it again.
I don't know, that wasn't a good one. Let's try another one.
This is 50-50, right? No, we need an NTR cap.
Well, that's good.
Little spiral down it, but I think we're right on top of it. Just a little nudge,
Try that, PK.
and hopefully that
Try
should
that.
just pop in.
Try drilling and see.
Yeah, there's a lesion there as well.
I think we are still on the vessel,
Or subminimal.
right?
Yep.
I think over there you need a little bit of a curve, and the wire is just straight. That's, I think.
I agree.
That might, if you're able to kind of reshape and somehow without losing too much up top, it may go at the level of that lesion.
I agree with you.
Well, that's the advantage of not having calcium that you see now, Dr. Guja, that with the calcium they wouldn't be able to advance this catheter over the
That's right.
not so well sized wire because they don't match. It's not
Right.
a 35 wire.
Right.
Um,
I think I felt like it popped.
There it
again.
looks
Try wiring it and see if I felt like it popped.
looks better. Oh
Nope, we're
No?
dissecting.
no, it's still
Dissecting
going in
it?
the dissection plane.
why don't you reshape
Cigarette?
the tip a little bit?
Let me make a better curve.
Yeah, a little bit more abrupt curve, maybe just.
So this is at this stage right now, we got to work in different angles, and we're going to have to try to use this catheter to steer us in. Sometimes you might get lucky without having to use a crossing device. I use an 035 catheter here to get down closer. Generally speaking, we don't do that, but here with the level of the popliteal, I felt pretty comfortable doing it. So at this stage, we're going to try to redirect this wire into it. If not, I may just go with an outback or an interior and try to just get in.
Do you think upgrading to a stiffer wire like the 018 Terumo you were talking about would help you in this case?
You know what? I've asked for it, and I think it's a smart move. I really do. I really believe that may be something that we can definitely try here. Let me just see whether I can just steer this, somehow into one of the fenestrations and try to get through.
Try that, PK. Try that. No, on the vessel.
It feels so right, but yet it's so wrong,
Right. So close, but yet so far.
No, you're going around it.
So, it's sort of like watching paint dry here, but that's kind of the,
That's the
We'll
deflection.
probably
I
try
think-
with a Terumo, either 18 or even like a straight 35.
all right, give me 018 Terumo guys here.
We have.
Well, give it a shot.
Try that, PK. Try that.
That's not going.
No?
I'm just dissecting.
Yeah, no. We are spiraling around that.
Yep. All right, so we're gonna go ahead and get the next one. I want is a fielder wire, guys.
You want to try NTR, PK?
Yeah, we can try it here, but I got to get lower. I need a torquer. The other thing is I'm going to pull this catheter back again, and try to redirect
Redirect
it
it.
from above. See whether I can pop in. If not, we're going to have to get posterior tibial access and come down.
Well, I guess before you get a post. Oh well.
Collateral.
That
looks good.
Collateral.
I was going to say if before we go to the posterior tibial access, it would be probably promising to
I
try
think
an
we got
NTR,
in.
but I think we're already in.
I think we're already in. We
Yeah.
got into one of the collaterals.
Yes.
Yeah, we're in. Off-road map. And go AP now.
Yeah. True.
Go RAO.
We'll
Well,
stick
that's
wire.
why they call it
So
glide wire.
now the whole
Because
thing
it
is
glides.
so George. Now the whole thing is we got to make sure we're in that perineal artery.
Yeah, exactly.
I think we are.
Exactly. As we said, the challenging of the angiogram is that we don't know where we're going to be after we cross.
Right.
Crossing is tough, and we don't know where we're going to be after we cross. So let's see now
PK,
that final
try it,
part.
1 second.
Where are we after
Take a
crossing?
DSA.
Yeah. Right.
If we're lucky to get a good target vessel, or we have to again kind of redirect a little bit. Let's see what's going on. A good angiogram. I think it's good.
Well, we're not in the peroneal artery, gentlemen, are we?
We are in the peroneal.
Well, you have to move it a little bit up and down. I think you
We are
are.
in the peroneal.
Probably go up and down a little bit.
Okay,
No,
one
this
second.
doesn't look.
Yeah,
Oh
yeah,
yeah.
that
I
looks-
think you are. I think
Yeah,
you are.
yeah.
I
Okay,
think
good.
you are.
Let's
Nice
walk.
job.
So now we're going to walk this out, and then we're going to go with the, we're going to get the 018 Trailblazer. Show me above. Get an 018 Trailblazer, guys. That's fine,
Yeah,
right?
yeah,
This
try,
way.
try to get this camera down, you think, Pika? And
I,
just
I, I don't think it's going to go. It's very
It might
large,
go.
isn't it?
It might go. It might go.
Okay.
Nah, why?
No.
Let's be elegant. Let's get a Trailblazer. So now we're going to put the 018 Trailblazer.
Particle wire, guys.
Get a Sparticle wire. The question is, George, how do you want to treat it, George, in today's day and age? What are the things that you do to treat this?
Well, I think, listen, I mean, as I said, this is a case that we don't see much. One can say that why don't we use a very small nano-cross balloon,
Okay.
and then we can perhaps do some imaging to see if we have gone subintimal for a long time or not,
You have it, Pika?
and
Yep.
understand a little bit more about the vessel. And
So
then
let's
we
get an
use
IVUS,
a little bit
guys.
more.
Let's get an
What do you
IVUS. I
think
got
about
it.
this approach? Like we
I
use
got a
like
wet
a
one.
2.5,
Leave it.
a 2.5 or something like that, nano-cross,
So let's get an IVUS right now.
and see how that goes.
So the whole idea here is now we're into the perineal. Now that we're into the perineal, the options are going to be very simple. I think what Dr. Dangus is saying as far as doing the IVUS is really going to help us to know what the modality of the treatment should be. If we're very subintimal, which I think we may be, then I think the answer may just be balloon angioplasty with a smaller balloon, sizing it with the IVUS, followed by a DCB, followed by possibly
I
a
have the wire, I
supera
have the
stent.
wire.
You got the wire?
Yeah.
Pull to me. If we're not very subintimal, then the options are more open
Yeah.
towards atherectomy. Hold on, this thing is wet. I need a wet one. Atherectomy, pull back a little bit. Okay, good. Atherectomy followed by, okay, now pull it to me. Hard. Good. Great. Atherectomy followed by DCB plus minus stenting. You know, the advent of the supera has really helped us in this particular area not to stent, but I think it's important, not to worry about stenting. Pull this wire out. But I think it's important to understand that the patency of any stent is going to matter regarding the runoff of that particular vessel. So right here we have very poor runoff, even though we have a perineal giving rise to two particular collaterals giving rise to the AT and the PT. So ideally speaking, this is not an ideal stent case. DSA guys? This is not an ideal stent case. Low mag, please.
No, because there are many branches that we may threaten some of them
Exactly.
and all that. So you
Oh, a
don't
little
know
lower,
what-
please.
But we have to go stepwise in order to understand better.
Yep.
But if we do a little work, then we're going to understand better how.
And I think
how
George,
you do.
I think George, your comment on the imaging is spot on, because the imaging clearly tells us, how we can do this, because the imaging is going to let us know, for instance, whether we can atherectomize, whether we can atherectomize, whether we need to stent, not need to stent, and also what's the size of the balloon that we can use to get an optimal result.
loop, okay.
So I think, obviously I'm
Take
trying to
it,
get the
take it,
loop
take it,
here,
take it.
which obviously I was able to get, so which makes us a little happier. So now Dr. Guja is going to walk this out, and we're going to run the IVUS catheter through. Now Sachin has a little data on a new stent that's recently been approved, RCC marked for tibial use. And I wanted Sachin to go over that stuff while we do the IVUS. Sachin, do you have those slides for the audience?
Yeah, sure.
Sachin, are you ready?
Yep. Thank you.
Speak.
Good morning. So, in infrapopliteal interventions,
DB and
what is the
lateral.
role of stents?
DB and lateral.
Traditionally, PTA, which is a plain balloon angioplasty, is done. It's safe, it's cost effective, works both on short and long lesions, but there is high failure rates up to 20%, and up to 15 to 30% of the patients will need some bailout stenting. Primary patency at 1 year is close to 50%, TLR 40%, with lymph salvage rates above 90%, so that's good. But what is the role of stents in infrapopliteal lesions? So this is a summary of all the old, the studies that have been done, including Achilles with 200 patients comparing DES versus a plain balloon angioplasty, Destiny DES with the BMS, Falkowski study with the DES with BMS, Yukon BTX with DES with BMS, and below DES with BMS. So if you look at the lesion lengths, they are pretty short lesions, less than 3 centimeters, but the patency rates are very good, close to 80% when compared to either BMS or PTA alone. Restenosis rates are on the lower side. TLR is also on the lower side in single digits. The limb salvage rates have been good, and it has been tried on both the sirolimus and everolimus drug-eluting stents. So what is the update on this? So this is the paclitaxel eluting stent below the knee 70 study. This is as all the drug-eluting stents we have are from the coronary balloon expandable stents. However, self-expanding nitinol stents traditionally yield better results in these type of peripheral arteries because they are prone to flexing, elongating, compression, and bending. So this is the first self-expanding nitinol paclitaxel coated DES. It's called Stentis from Paris in below the knee interventions. So this study is multi-center, single arm study, prospective. 6 and 12 month safety and effectiveness of this stent in CLI patients. So 70 patients were enrolled in 5 centers in Belgium in 2012 and 13. Lesions has to be more than 50%, reference vessel diameter between 3 and 4.5 millimeters. But here also they included a shorter lesion, has to be less than 50 millimeters. They excluded, any patients who had a prior bypass or distal amputation, untreated inflow or ISR or severe calcification. And in this study, pre-dilatation was mandatory. So mean age of close to 75 years, close to 50% has ulcers which are non-healing, 40% diabetic. So mean lesion length that was treated is close to 20 millimeters. So it's again shorter lesion. Good technical success, procedure success. Primary patency rate close to 70+%. Freedom from TLR is 79%, and limb salvage rate is close to 98+%. And that's why this study, this stent has been approved in Europe. So comparing to the other drug-eluting stent studies, and if you see at comparing to Yukon, Destiny, and Achilles, there's a good primary patency rate at 1 year, compared to BMS and PTA, which traditionally is close to 50% primary rate. And also the patient Rutherford classification of these patients comparatively improved, who are having a non-healing wound as healed, and then they become like more of a mild to moderate claudicants in a 12-month follow-up. The another study which has been published recently is a PADDY trial. It's again a study comparing DES compared to bare metal stent after PTA for bailout. And as you see in interventional cardiology, DES has shown better patency rate and now is standard of practice. So that's an investigator-initiated multi-center randomized trial. The primary endpoint was 6 months primary binary patency, which is defined on CT angiography if there is more than or less than 50% stenosis. And you see that they treated 74 limbs with the DES and 66 limbs with the PTA plus or minus bare metal stenting for bailout stenting. And here the 6 months patency rate is 50% in the DES versus 35%, but this is done on CT angiography, showing if that's more than 50%. Fewer minor amputation occurred after DES. And the conclusion of the study is, drug-eluting stent provide better 6 months patency rates and fewer amputation after 6 and 12 months compared with the plain balloon angioplasty plus or minus BS. So these are the current trials, and these are the role of stents in infrapopliteal lesions, so in CLI patients. That's all I have, PK. Back to you.
Now let's play the IVUS. So we did the intravascular ultrasound, and I want to show you guys what the intravascular ultrasound showed. Let's play it. So Dr. Guja, you want to just read it? So we started in the distal posterior tibial, not distal, proximal posterior perineal, excuse me, where we re-entered, and now, or where we thought we re-entered, and now we're going to pull it back. Okay, okay, there we go. So now you're going to see a very slow pullback, and what you're going to see is you're pretty much intraluminal all the way through. Go ahead, Doc Karthik.
So this is coronial. So we are trying to pull it back, and you can see here that
Wow, that's impressive. So that's all distal popliteal.
Yeah, exactly. And the vessel is 1, 2, 3, about 4.5. Yeah, good.
It looks like it's all fibrotic, extensive amount of plaque, guys. So we are a little eccentric, but we are definitely within the lumen. Right at this point, it looks like we are slightly in a dissection plane, but very eccentric. But we make an eccentric cut with directional atherectomy catheter. We might be able to debulk everything. But if you really come look at this, we are completely within the lumen.
So I mean, I feel very confident here. So what we decided to do is go with an ES plus catheter, and you can probably use any moderately sized atherectomy catheter. And you want to point it away from the collaterals. Turn it on, please. So we just pointing this away from the collaterals and just making a very small cut. Obviously, there's always a risk of perforation when you do any sort of atherectomy, especially in the CTO. But I mean, you know, we've done enough of these now to not worry too much about that stuff. You know, obviously, if it's the first time you're starting out, imaging does help. You know, off please. Imaging helps to be able to help you to see where you are. So now we made one cut, and we're just going to make 2 passes here, and then go ahead and take a picture. On. So we're going to make 2 completely opposite directional passes. You know, we're actually obviously directing it away from any branches if we can. But I'm not really too concerned here. I got the IVUS to tell me which way to go, and I'm just going to take it all the way down into the perineal. As you saw, there was very diffuse plaque, you know, inside the entire vessel here. Okay, off, please. Okay, now I'm going to take it out. Now we're going to make a DSA picture. I think here it's very important to remain disciplined and not, senor, don't move. So whenever a patient moves like that, you have to worry about other stuff, you know, perforation or whatever. And if it is, you deal with it. But here, as you can see, there's really nothing to worry about here. You know, you've got a nice popliteal artery that you've pretty much reconstructed with 2 passes, and you have you have to deal with it. So now, like Dr. Dangus said, we can actually now size our balloon. So Dr. Dangus, I mean, you agreed with us it was about a 4?
Yep.
Yes, exactly. It's about 4, easily a 4. So
regular 4.
For a long DCB, I think would be
yeah.
the next best step.
So what we're going to do here is we're going to go with a 4-0 nanocross as suggested by Dr. Dangus, and what we're going to do is we're going to leave this up for about 3 or 4 minutes, and then take another picture, and then likely we're going to head into the DCB. You know, I think this case is important because it really illustrates, you know, it's a complex lesion. You know, if you look at this lesion, you don't have a stump. You kind of think you have a collateral or a channel. You just have to, you know, go there with the right equipment, probe it down, and see where you're at. To me, I think the keys to this case is understanding the equipment and the limitations of the equipment. So first and foremost, you need a steering catheter. If you don't have a steering catheter, you're always going to get into the wire, into those collaterals. So it's important to have a steerable catheter. Number 2, you need to go with a wire that's not hydrophilic. I know that it goes against the classic teaching in some ways, but I think a non-hydrophilic wire will tend to a hydrophilic wire will tend to prolapse into the vessel of least resistance, and in this case, the patent collateral arteries. So we went with a Confianza wire, which is a non-hydrophilic, very penetrating tip load wire, and then we just went ahead and we were probing using the catheter exactly to find that ostium of the CTO. Important to this is what Dr. Dangus and Vishal said earlier is that you want to go to multiple angles to make sure that you angle this particular wire away from those collaterals and make sure that you're entering at the right spot. Finally, once you get through, you need a support catheter. So support catheters, obviously you can use any support catheter. I think all of us here try to use catheters that are cheaper, and obviously a Aqua Tempo 125 is a lot cheaper than some of the other catheters out there. So we use that to get close, and then we escalated our wire to an 018 wire. You could have gone with an Ashtato. I feel that Ashtato is not very torqueable in my hands, so therefore I went with a Glide 018 gold tip wire. Once you're in, you confirm your position. I think the use of intravascular imaging in these particular cases is incredibly important because intravascular imaging, like Dr. Dangus suggested, will help us to size the balloon, know where we're on the vessel, and choose the appropriate therapy. So right now we've done it, and now we're just ballooning it. And after ballooning it, we'll decide what we're going to do.
So let me ask you, BK, what's your experience with, how we use CTO devices in SFA, especially in cases like this in the popliteal? Do you think there is a role for them?
I think here, Vishal, I think you have to be prepared to get multiple accesses to do this case. I think first and foremost, we had the ultrasound machine ready to get the posterior tibial artery. Now, if this was an ulcer patient with an angiosome distribution at the level of the posterior tibial artery, I think it would be imperative that we get straight line flow. Although indirect revascularization can heal the wound as well.
Right.
So here our goal was to get in, because remember, when we looked at the initial anatomy, we saw that you had the anterior communicating artery giving rise to the DP, posterior communicating artery giving rise to the PT. So we could get flow into that territory. Number two, to answer your question about CTO devices, I feel in the popliteal it's all your level of expertise. If you're very well versed with these CTO devices like the Viance and other devices, Front Runner, whatever it may be that you're good at, then I think you should use it. Crestor, you should use it. There's also another recent catheter that's out that we're starting to use called the center cross catheter. I know Dr. Dangus has some experience in it in the coronaries, but I think that catheter has been shown to work really well in the peripherals as well, although our experience with that currently is limited but will be growing. But I can tell you that to me, it's all dependent on your comfort level and what you're good at. We're very good with wires and catheters, and we're able to get through with just normal stuff. But if you need those tools, they're out there, and I think you should use them.
Right. All right, let's see what's going on in the popliteal vessel.
So now, Vishal, so you have a prolonged balloon, 4 minutes to be exact. Dr. Guja kept it up. Now we're going to walk this out. And, the idea is important is I want to ask George. George, would you stent this? And if you would stent it, what would be the factor that would make you stent it?
Well, you have to have a really flow limiting dissection or something here to consider the stent. I think the post-procedure, post-balloon angiogram is going to be very important after some nitro and all that. That's another aspect we have to be careful. There's so many vessels, the small vessels, the wire went different places. You got to really allow the vessel to relax a little bit and give nitro before your final angiogram to have the most reliable picture of what's going on.
So they're going to take a nice picture here, post-balloon.
Wow.
You see? So there's a little bit of a dissection plane distally, probably a little bit oversized in that spot, with the balloon. I think Dr. Dangus, your point about the collaterals, I think is very, very important here. I think these genicular collaterals are the reason why this guy was able to heal the wound that he had after Dr. Guja opened up the SFA. And I think for the audience, it's important not to look for that stent-like result all the time. We know with the drug-coated balloons, especially in the impact real world and the Lutonix real world data, that the patencies are quite good at these real world type lesions, including CTOs. So I think, these dissection planes, if they're not flow limiting, like Dr. Dangus said, maybe okay just to leave it alone, with a DCB and just leave it alone, although it's starting to look pretty crappy right there.
Well, that was a lesion there was a lesion there, and you tried to bypass the lesion. It was a little bit roughing up of that lesion there. So there may be a focal area there to consider. Well, the two things that I would advise, one is perhaps to consider doing the IVUS again.
Yep, that's good.
The other one is, since this patient is probably on Plavix already, because on the previous intervention, do a platelet activation assessment, platelet inhibition assessment, I should say, in order to see maybe you can, you really need to have a very good platelet inhibition from now on, particularly if you don't stent. So you're going to be sure that there's no some form of platelet, Plavix non-responsiveness or something.
Well,
that would be a good test to do.
That's a great point. As you know, as Sachin went over the trials with DES below the knee, all of them, Achilles, UConn, you name whichever trial you want to talk about. Clearly, the patency rates are definitely improved with DES if you need to. So if you are going to stent this, you can use a DES. I agree with you, George. I think what we're going to do here is we're going to do a prolonged balloon with a DES. We're going to give copious amounts of nitro. Actually, first we're going to IVUS. Then we're going to give copious amounts of nitro and do prolonged DES. After which, unless there's a complete vessel shutdown, we're not going to do it. We're not going to stent this. I can tell you that our threshold for stenting at this level is going to be very, very high.
I agree.
So let's see how this IVUS looks. We're right on time, so we should be able to finish without an issue. So you can see here, right here, that the intravascular ultrasound shows a very small popliteal artery and perineal artery.
But
And
the
you can
vessel is very smooth so far, that's great. We have a little bit of a spasm here, some residual lesion. I think that's probably where the lesion is, in that area.
And you can see, he's coming back really slowly. We're not to the lesion yet. You can see how small this vessel is.
Yeah, it's a 3 vessel.
There, that's the calcified area. Keep coming, you can see the dropout there. You can see it's just all plaque. There it is. There's a dissection, probably the lesion. And you can see that this is the area, there's a dissection.
Right there.
That's the area that we saw. And I think we're just going to leave a prolonged, there it is again, a prolonged DB. Get a 40120, guys. We're going to go up with a 40120.
Yeah, leave it long time and test the platelet activation. Great.
So one of the things Dr. Gujo wants to do is reatherectomize. Turn it off. I think here, Karthik, I think you've done a reasonable job. You have a good lumen. Just go ahead and DB it. I think you'll be fine. So let's go ahead and DB it. Guys, our waveforms are good. Our ACT is good, Liz?
Doc Dangus, I mean, unfortunately, I'm a no stent guy. I don't like to stent unnecessarily, but if he had an ulcer, I would have probably stented this pop and into the peroneal with, or at least the focal spot of the peroneal where the dissection is, with the DES. But on claudicants, I don't think stenting the popliteal is any answer. I think DEB will give pretty good results, and it will stay open. If they restenoze, you can always go back and do it. It's just still percutaneous procedure. But I think for claudicants, stenting popliteal is not an answer.
Yeah, no, I totally agree. I would probably just keep the balloon at the proximal end of the peroneal artery and more so in the popliteal segment because it's a smaller vessel down there.
I mean, the maximum it can happen is he'll restenoze, but you always have a choice of stenting. But once you stent, I think you're just stuck with limited options for him.
So now we're going to go with the DEB. It's a 40120 impact. And as we've gone over multiple times, the data with the impact DEB is quite impressive, as is the Lutonix. So we're now just going to go ahead and use this at this level, and we're going to leave it up for about 4 to 5 minutes, and just leave it up prolonged DEB, sort of really massage that vessel into behaving.
Stop.
And we're just going to try to get it down there a little bit more. I'd go, yep, that's good right there. Yep, that's good. Little dive from above. Make sure you're covering the proximal end. We're just going to make sure we're covering the proximal end. Show me above, guys.
Wire it down?
No, we got to come back. See, we got to come back a little bit. So remember, it's important for the audience. You want to cover the area that you've actually injured with the atherectomy and that you've crossed to. That's good. That's good right there. So I think we're at the proximal level, right above those collaterals. So we're going to go ahead now and just leave it up. Dr. Guja is checking the wire position, which again is an important discipline to have to make sure that you're not screwing up the position of the wire. And perfing any little branches with the wire going somewhere. The second thing is the wire itself can knock out the anterior communicating and the posterior communicating artery, creating problems for you. So you can see that the DB is large here, so you're going to have to be really slow. And you can see he's just going to go up just to expand it at that level, and just to get it up to, maybe a 4.0 or so. What are we at right now?
We're at 4.
4 atmospheres. Nominal is 8, guys? 8. So nominal is 8. So we're just going to go very, very slowly and leave it up.
Our plane is at 14, right? Right where the bend is. I think that's where our plane is.
Right. So right now, it may not be a bad idea to switch out for an 035 wire unless you think you're going to stent. So, this is another little trick if you're going to save money, save time. If you don't feel you want to stent, you can put an 035 wire down and just pull out the system with an 035 wire. This will save you time to recross, put an 035 wire down, and then take your sheath out. These are the kind of little tricks to keep things being a one step ahead of yourself to make sure. So right now we got 7 minutes left in our transmission, and right now we've got this balloon up for the next 3 or 4 minutes. So any other thoughts, guys, on what else you would do?
No, I think this is the optimal management of this. We have to be a little patient and see how the angiogram looks after this prolonged balloon inflation with a drug-eluting balloon.
And George, if you had to stent, say you had a flow-limiting dissection, Vishal, yourself as well, what are the stents you guys would choose? Let me give you some choices. Would you use a coronary DES? They come now in 4.0 stent sizes. Would you use that? Would you use a Supera? would you use a Zilver PTX or just a regular bare metal peripheral self-expanding stent?
Well, I mean, no real data here, but I would say that if we have to stent in the proximal part of this occlusion, I would favor the Supera, but if we're stenting below the level of 10, a little bit more in the tibial, so to speak, area, the peroneal vessel, I would probably favor the coronary drug-eluting stent.
Yeah, for me the sizing will be important, right? Like you said, it'll be very focal stenting first of all, because we just want to just cover the flap and keep the patency up there. But if it's more on the proximal end or in the popliteal section, then Supera should work great, especially if you've already DCB'd well. And distally, again, you could go both for a bare metal or a drug-eluting stent. You can argue both ways. One would say that the drug is already deployed in, so what's more benefit of adding another drug-eluting stent versus just for your own satisfaction, put a drug-coated stent and get away with it. But again, keep it very short, very focal, and hope for the patency to be there.
I think both of you make great points. I think that what George was saying and what you're saying, I think, makes a lot of sense because you already have delivered the drug by the impact balloon. So now you can just limit your stent, focal stent it. And I think what George is saying is the flexion points are where he would probably be concerned and use a Supera versus the non-flexion points where you could probably get away with either a regular bare metal or a coronary drug-eluting if you didn't already deliver the drug there. So how many minutes is that, guys? 3 minutes?
3 minutes.
So we got another 10 seconds, another 50 seconds more. We'll take a picture, and I think we'll probably be done, God willing. Let's see. So let's send me that, please. So this way for our records.
We did.
Yeah, you know what I'm saying for.
We saved it.
Yeah. Okay. Good. Get down. Excellent. So now we're going to take a couple of pictures, and then we'll be done. We'll be done hopefully here. All right. All right. Let's see now. Let it deflate all the way before you take it out. Liz, can we have some Nipride, Liz?
Nipride, we're going all the way here with the vasodilator.
Well, yeah, we want to vasodilate it. You know it.
You know what I'm bioabsorbable stents will be probably the future for popliteal and below-knee stenting. Probably the best way to do it.
Which stent is that?
Bioabsorbable
Oh,
scaffold. Yeah.
Still a little way to go, but yeah.
George, you have a lot of experience with the bioabsorbable scaffolds. I mean, how are they going to be crush resistant or what?
Well, not really. There's going to be kind of either resistant or it breaks in pieces. There is no in between of that one.
That's exactly it, right?
I don't think that I would consider absorbable in the flexion points, but again, in the area with the peroneal, it's more straight vessel and all that. I think we may be like at 14, for example, which looks in between 14 and 15. That looks to be your lesion of kind of concern a little bit. If you can take it out of the bone, we could use a short one, I suppose.
Yeah, bioabsorbers are very stiff stents, especially in the coronary deliverability. So
That's beautiful.
I don't know how it's going to work.
I think it looks very good. I mean, I'm very happy with that. Looks much better than before, and I think we're done.
Yeah, we're done, George. We're gonna take some pictures below. Take another picture. Leave the wire.
No, leave the wire.
So we're just we're gonna take a couple of pictures. Your pressure's a little low. Inject.
Just on the
we did give quite a bit of nipride. That's good. There's a little bit of a spasm from the wire. I think you're doing a good job with the nipride. There are many vessels distally. I think this foot is perfused really well. So we'll
just take 1 foot shot here, and then we'll sign out. George, Vishal, thank you very much for moderating this. And I think, like you said, we got it done in an hour or less than an hour. It was a pretty complex case. Again, I want to thank Liz and Cristobal and our entire team here, especially our communication team. Thanks again, you guys, and we'll see you next month. Thank you.
All right.
Thank you, guys.
Great job.
Great. Congratulations to the team in the lab. They did an amazing job.
No clapping. That's not us.
Less than an hour, this complex popliteal with the complex recanalization techniques, multiple angiographic views. The importance of angiographic views, I think, was a key here because there were so many collaterals, very difficult to see. The use of the specialized wires, the crossing, the use of IVUS in order to select the equipment to use according to if you were intraluminal or not, and the DB all worked very well, the vasodilator in the end. I think every detail was attended to, a great result. Let's meet back here on the 27th of April, same time, anywhere you are around the world, or at 8 a.m. in New York Standard Time. And Vishal, won't you tell us a little bit what's happening with the conferences and the dates of those? Just give us a reminder.
Just a reminder, the annual conference is scheduled for June 14th to 17th. Specifically for the endovascular fellows, we have a great conference on June 14th, which includes this time a cadaver lab for getting hands-on experience in peripheral intervention. So do come in, join us, log on to cccsymposium.org for further details. And like Dr. Dangas said, we'll see you next month, same time, 8 o'clock Eastern Standard Time. Have a great day.
All right. Goodbye from New York Cath Labs, Mount Sinai. Have a good day.